Well, good afternoon and welcome to Paris. We've just finished our workshop on enhanced recovery here at the International Forum. My name's Tom Wainwright. I'm a clinical researcher and quality improvement specialist from the Royal Bournemouth Hospital in the UK. I'm sat here with Rob Middleton, consultant orthopaedic surgeon, and we've been asked just to talk for the next 15 minutes about some of the key points about implementing enhanced recovery. Welcome, Rob.
Thank you, Tom.
I thought I'd just sort of kick off and sort of get you to explain how you became involved in enhanced recovery and talk about, you know, that sort of process and what's brought you to be presenting here at the forum.
It was about 10 years ago. I was working at 4 different hospitals. I work at 2 state and 2 private hospitals, and I specialise in hip replacement. So I was doing essentially the same operation in each of the 4 hospitals, same technique, same implants. I used the same post-operative management, and the hospitals all within 9 miles of each other. And one would have thought that the outcomes from those hospitals would be the same. But when I actually took the time to look at the outcomes in terms of length of stay, complications, patient satisfaction, I found them entirely different. Each hospital had a different set, and that brought about a fundamental change in myself. I thought up until then that I as the surgeon was the most important thing, and as long as I did the operation, oversaw the management, that everything else would fall into place. But what I realised was that that was important. Doing a good operation on the right patient was important, but it was all the process and other things around there. And that took us, as we worked together and we investigated, we've worked out that normally any process, about 20% is natural variation, is due to the patient, the complexity of the case, and you can manage that variation, but about 80% is artificial. It's the processes that we put in to deliver care, and you need to eliminate that artificial variation by putting in processes that work.
So enhanced recovery then, it's a multimodal strategy. It's getting lots of different process steps correct. What would you say are the key points in orthopaedics, and especially hip and knee replacement? What are the key steps at the pre-operative, intraoperative and post-operative stages?
Well, if you break it down, as you say, the pre-operative, I think one of the key things is the hip and knee class that we do.
And so what's that?
Well, we have a great variety of patients of all ages, sizes and shapes and comorbidities, and it's to allow those patients to know what's going to happen to them in hospital beforehand. So we set up the class. It's normally 1 to 2 weeks before the operation. The patients come, and it's not just the patients, it's their relative or carer with them, and that's quite important. They're coming from the community and going back to the community. And we have about a class of about 30, so there are about 30 patients and about 30 relatives or friends. And we have an hour session where our unit presents to them. The important thing is it's not just the people from outpatients to present, it's the people who they're going to see on the wards afterwards. So our nurses, our occupational therapists, our physiotherapists, our ward sister come and speak about each area. We actually show slides, or PowerPoint these days, of actually what the ward looks like and what they're going to do. And we find if we take them through that process, it demystifies it and they know what to expect. Also for their families as well, one of the key things is learning to use, say, crutches. Now, to some people that comes straight away, but to others, if we teach their son or their daughter how to use the crutches, they've still got a week or 2 to practice with the crutches before they come into hospital. It's also key for our staff because our staff lead and give the tutorial to the patient. So it means that they're keeping up to date with what is happening, and it's empowering them as well. And we make it an essential part of the training. It's really see one, do one, teach one. So all our staff who rotate through the unit have to go along and watch one of these sessions. Then they get the chance to present part of it, and then they get the chance to teach it to another new member of staff. And it means that all our staff are singing from the same hymn sheet, that they know what the processes and plans of the unit are.
So that's really interesting. You're talking about there the importance of managing that patient's expectation of what's going to happen to them when they come into hospital. But not only that, managing their family's expectation, but also your staff's expectation. I think that's quite a key point you raised there, that singing from the same hymn sheet. Everyone needs to know what's going to happen and why it's going to happen, and how it's going to happen every time for every patient. That touches on some of the cultural aspects of introducing enhanced recovery. We know from the conference here over the last few days that improving services, improving quality is a large amount to do with teamwork. What insights can you give us about how to promote good teamwork in order to implement enhanced recovery?
Well, I think you hit on a key point. It is not one individual. You certainly need someone with leadership skills. It has to be often someone who's got some vision, but they need to work within a team and gather a team around them. The most successful way that we've found is finding a representative of each group, whether it's a physiotherapist or anaesthetist, and it doesn't have to be the most senior person. Sometimes they're actually the wrong people. It's someone who's enthusiastic about their job and wants to try and take things forward. And we find if you get those like-minded people together, that they've got all the solutions for their own unit. We can give direction from things like the IHI and BMJ and things. There are literature reviews and things, but most people know what the best things to do, and it's to try and get those together. We delegate the responsibility. It's certainly not control and command. You need someone who's leading the team, but it's to say, well, you're representing, say, physiotherapy, that in the ideal world, what would be the optimal physiotherapy to give patients before and after an operation, and then it's the job of the rest of the team to see if we can choreograph that into the whole overall programme.
I mean, that's interesting, isn't it? Because all these staff have obviously been working in the hospital already. Why haven't they made these changes? Quite often when we see enhanced recovery introduced in other hospitals, as you say, the ideas for change have been there, but they haven't quite brought them all together. How do teams go about bringing those things together? You've mentioned leadership there, you've mentioned getting a core team together. Is time frame important? Do we need to give these things a long time to develop, or is actually a shorter time frame the way forward?
Time frame is a key thing. But it's counterintuitive. It's not what you think. This is not a 6-month, 12-month, 18-month project. From working both in the UK and internationally, the projects that take the longest are the least likely to succeed. The ideal time frame we found is about 3 months from putting a committee together to implementing the change. And the advantage of the short time frame is that people have to make decisions. Otherwise, they just sit on the fence, or we'll do a bit more research or ask a few more people. They're normally not critical decisions, but they're decisions that need to be made continually. So a 3-month period. I think the two things that make the biggest difference to empowering the team are the two rules that we had. One, that we wouldn't do anything because that's just the way we'd always done it. And the second, that you could only introduce a change if there was some positive benefit for a patient. So that last one is patient-centred. Everything we do is patient-centred. It's not for you or me or for the unit, it's for the patient. So everything has to have that. And that first one, a lot of the models of care that we got are traditional. It's the way that we've always done it. Now, if that way is the best way, and there's evidence for that, then obviously we should follow it. But if it's just always the way that, oh, we always keep the patients in bed for 2 days after an operation, and that's the only reason, then we should do something different. And I think once you explain that to the team, that those are the two principles, they are then able to identify their own goals and methods to get there.
So that's interesting then. A short time frame forces and sort of energises the team to make the changes and get things done. Moving on, we're obviously talking here about surgery, and we're at a quality improvement conference. Why, say, is orthopaedic surgery such an important area for our health systems to improve? I'm thinking more perhaps of the numbers of patients that we have to treat.
I mean, orthopaedic surgery treats two groups of people. One is trauma, so people who injure themselves, and they tend predominantly to be older people with osteoporosis, and also degenerative joint disease, arthritis. We're all living in societies now that are ageing. There are more older people and they're living longer, and so the demand on our services is greater. So if we take probably the commonest emergency operation, you're probably looking at fracture neck of femur, people who break their hips. If you're looking at the commonest elective operation in the Western world, that is actually hip replacement. If you look at hip and knee replacement and put the numbers together in your hospital or in the country, they are many times, often 5 or 10 times, all the other operations added together. So it's the biggest group, and that's the important thing, is if you're going to start on an enhanced recovery programme, you want to get the biggest return at the start. So choose the biggest group, which is normally orthopaedics, and in particular hip and knee replacement, and get that right. And the lessons that you learn from that can then be cascaded down into the other subspecialties within orthopaedics, but also out of that. But if you don't sort that, and for example, if both hip fracture and hip replacement, not only are they very common, but they take the biggest number of bed days as well. So you'll find most of the bed days in your unit are actually around those two areas.
So that's a really interesting point that perhaps we needs flagging up sometimes. We're looking here at quality improvement across health systems, and we're talking about surgery, but then within surgery, in orthopaedics, we're talking about procedures which are extremely high volume and in highly sort of resource intensive in terms of the beds and capacities which are required within hospitals. One of those that you just touched on there was fractured neck of femur. Now in England and Wales last year there were 66,000 fractured neck of femurs across the country. Do you want to just tell us about some of the work you've been doing at Poole to both improve the quality of outcomes and also reduce the length of stay there, because the results have been impressive?
Well, Poole, where I'm clinical director of trauma there, is one of the biggest hip fracture centres in the country. We actually have 1,000 patients a year who break their hips. And probably in the past, it's one of the most poorly researched and improved areas as well. And we looked to change that. We started with elective. And the key thing about fracture neck femur is these are very old and frail patients. If you get something wrong or don't get something right, there's a big penalty paid. We know mortality is high and morbidity is high. Our length of stay for fracture neck femur was approximately 21 days per case, which actually is what the case mix adjusted suggests, that in the whole of the UK.
That's about the national average
quite
as well.
average.
Yeah, within the UK.
And we introduced the same procedures for enhanced recovery, pre-operative, intraoperative, post-operative and rehabilitative. And we decreased that from 21 days down to 11 days. Now that's made a huge difference, not only for those individual patients who their mortality has fallen, their morbidity has fallen, 50% have got back to the accommodation they were in before, where it was about 25%. Before that, we doubled the number of patients.
So that's interesting. You've reduced the length of stay, but it's not a case of moving that burden onto the community care. You're also saying that you've doubled the number of patients that have gone back to their place of normal residence after that pathway.
It was quality. It was the nurses. When we asked the nurses what they wanted to do, they wanted to see more patients going home to where they came from. They didn't feel that it was right that 3/4 of patients ended up in a nursing home or a rest home. That was difficult at the start, because when we first introduced enhanced recovery, our length of stay didn't fall. In the first year, it was roughly about the same, but we doubled the number of patients going home. And I stuck with it. I said, we're doing the right thing, and as we keep doing it, it'll come in. And as we fully introduced enhanced recovery, then the length of stay came down. We now save 10 days over our case mix adjusted. So that's 1,000 patients saving 10 days. That's made a dramatic improvement to our unit. We've reduced the number of beds we've got, so it means that we can use our doctors and nurses more effectively. It has also freed up beds in the hospital for other subspecialties as well.
So, I mean, those are really sort of impressive numbers, because the national average length of stay for fractured neck of femur at about 21 days, the case mix adjusted 10 days shorter. So you're saving about 10 days per patient for 1,000 patients a year in your hospital. The potential for this to help the UK health economy if other units adapted the similar approach is massive.
It would make a big difference. It's the aggregation of marginal gains in all those admissions. We're trying to just improve things for each of those patients in each area by about 1% or so, and you can put that together at the end and it makes a big difference. And there's nothing special about my hospital. Certainly in the work I did for the NHS Institute for Innovation Improvement, I visited and worked with trusts across the country. And the work that we did looking at the successful trusts, there was no association with how big the hospital was. If it was a small hospital, it could do as well as a big hospital, whether it was a teaching hospital or not, whether it was a brand new build or whether it was a decaying building. Those factors didn't matter. The factor that made the big difference was the team, the desire. If the managers and clinicians on the ground were committed to change and wanted to improve their services, then almost inevitably they did. It was that commitment from the team, not the resources they have. So I can see no reason why what we achieved is not replicable. There is no single magic bullet. It is getting each of those steps right as enhanced recovery dictates.
So I mean, what we've just sort of covered just in that conversation, also the workshop, we've seen that quality and all the dimensions of quality are sort of improved by enhanced recovery, but also there's significant productivity gains to be also realised if all units adopt this approach. Why do you think that every unit isn't doing the same thing? How do you think we can engage with other units across the UK and across the world to help spread this message of doing all of those, those simple process steps correctly, that sort of aggregation of marginal gains you described? How should we be spreading this?
I think a lot of hospitals and probably most, if not all, have signed up for enhanced recovery. But it's a question about meticulous and actually introducing it. Just saying that you're doing enhanced recovery or picking and choosing the bits that you like, or the easy bits, is not enough. We wrote an editorial in the Dr. Foster magazine last year where we looked at hospitals who had introduced 7 key indicators of enhanced recovery. Simple things such as the pre-admission class, such as admitting patients on the day of surgery. So just some very simple indicators. And essentially all the ones that had brought in all those simple indicators were the hospitals that had the lower length of stay. Hospitals that had decided against one or more, we found were in the bottom half and had a longer length of stay. So I think it's been meticulous. You can't just do brilliant surgery or have brilliant physiotherapy. You've got to get each one through.
So is it something about you've got to have the clinicians, the leadership, the clinical leadership, and you've got to get those clinical decisions right, but then also you've got to get that quality improvement methodology correct as well. You've got to have a system and a process change that accompanies these clinical steps in order to make it happen.
I think you're right, and it's not something you can just do in your spare time. Clinical staff and managerial staff are busy. They can do some of the work, but you need someone coordinating it. And one of the key innovations that we've seen and we've used ourselves is having a pathways manager. Now, that can be permanent or it can be over a period of 6 to 12 months. But you need someone coordinating all the different groups because we can't stop work to do this. We can't close the hospital for a day or a week to learn that. So often the pathways manager is someone who will have experience of change or will have gone off and done the courses and things and can coordinate the different groups, the anaesthetists, the surgeons, the managers, things, to bring that change through. It is actually a minor investment in a huge improvement. As we were talking earlier, 1,000 patients, 10 days per patient, the actual cost of employing someone to do through that. So I think if you can second someone from the hospital to do that's fine, or it's a question of getting someone in to work with you. And that person, once it's gone through, say, orthopaedics, can also work in the other subspecialties after that to deliver it. But I think that is a key point.
Great. Well, thanks for giving up 20 minutes to talk with us, Rob. We've had a great time here at the International Forum. We've really enjoyed doing the workshop where we covered some of the key points of enhanced recovery. And we hope that the conversation we've just been having there gives you some top tips for how to implement enhanced recovery in your organisation. All it leaves me to do is sort of say thanks to you, Rob, and thanks to the guys filming it. And that's all. Thank you.